Welcome back to another deep dive. I'm super excited to be your guide today, mostly because we're tackling a topic that is literally a game changer to teach and to learn. Whether you're a student trying to ace those upcoming clinical exams or a seasoned pro looking to deliver absolutely stellar, compassionate patient care, getting a grip on cognitive disorders, it's non-negotiable. Today, we're breaking down the critical, and I mean critical, nuances between delirium and dementia. By the time we wrap up this explainer, you're going to have a rock-solid, structured understanding of exactly what separates these two heavy hitters. So here's the big question. How do you tell the difference between a temporary cognitive lapse and a permanent decline? Just picture it. You're walking the hospital floor. A patient who was perfectly lucid yesterday is suddenly confused, totally disoriented, maybe even agitated today. Are you looking at the tragic onset of a lifelong disease? Or is this a highly treatable, acute medical emergency? The stakes here? They literally couldn't be higher. One path demands an immediate life-saving intervention, while the other requires long-term, really compassionate care planning. Okay, let's dive into this. Here's our roadmap for today's explainer. First, we'll look at the cognitive disorder spectrum. Second, delirium, the acute emergency. Third, dementia, the gradual decline. Fourth, we'll do a head-to-head contrast, a real masterclass. And finally, management and treatment strategies. Let's get to it. All right, starting us off with Section 1, the cognitive disorder spectrum. Moving right along to Section 2, delirium, the acute emergency. Now, delirium moves fast, right? So we're going to move fast too. Let's break down this definition. Delirium is defined as an acute disturbance of attention and awareness. And when we say acute, we mean it hits rapidly, usually over a matter of hours or maybe a few days. But the absolutely crucial word here is fluctuating. The patient's presentation is going to bounce all over the place. They might be relatively clear-headed in the morning and then just deeply confused by the afternoon. This primary disturbance also brings along extra cognitive baggage, sudden issues with memory, orientation, language, or perception. But listen, here's the most important thing I can teach you right now. This is not a primary psychiatric event. Nope. It is a direct physiological consequence of something else going haywire in the body. And that fluctuating nature, it builds right into a hallmark clinical feature you've probably heard of, called sundowning. Since delirium inherently fluctuates, you'll very often see a patient's symptoms get significantly worse at night. The lights dim, the day winds down, and boom, their confusion and agitation just skyrocket. That right there is a massive red flag for you when you're out walking the wards. What's genuinely fascinating here is the underlying biology. See, delirium isn't exactly its own distinct disease. It's really a broader biological disruption of brain metabolism or neurotransmission. We're talking about acute medical triggers, like a gnarly infection, nasty medication side effects or interactions, recent surgery, anesthesia, substance withdrawal, or even a metabolic imbalance. And you've got to be hypervigilant here, because these triggers, they are incredibly common in older or medically frail patients whose biological reserves are just already running low. All right, let's slow things down for Section 3. Dementia, the gradual decline. So we're shifting gears now. We're moving from that rapid-fire acute emergency to a steady, progressive, and gradual condition. In clinical terms, dementia is called a neurocognitive disorder, or NCD. The definition here is a significant, or sometimes modest, acquired decline from a previous baseline in one or more cognitive domains. We're talking areas like complex attention, executive function, learning, memory, language, perceptual motor skills, or even social cognition. And there are two core requirements to make this diagnosis. First, there has to be a documented concern, maybe raised by the patient, a family member, or a clinician. Second, it absolutely must be confirmed by objective testing. That testing is clinically vital. It's exactly how we separate a true neurocognitive disorder from just, normal age-related memory blips. We're looking for a measured, documented progression. So the crucial point is understanding the severity scale, because this dictates exactly what kind of care the patient needs right now. The dividing line here is independence. In major neurocognitive disorder, the cognitive deficits actively interfere with the patient's independence in everyday activities. They might need help paying bills or managing their meds. On the flip side, mild NCD means the deficits do not interfere with independence, though the patient might have to put in a lot more effort or use workarounds to get through the day. Mild NCD is specifically set up in the DSM-5 to capture that very early decline, which is awesome because it lets us jump in and teach compensatory strategies way earlier. Now, the DSM-5 also requires us to specify the etiological subtype, which is all about the underlying biology. Alzheimer's disease is the big one, the most common cause. It features this progressive buildup of amyloid beta plaques and tau tangles, plus cortical and hippocampal atrophy and the loss of cholinergic neurons. Next up is vascular NCD, which typically pops up after a stroke or from chronic cerebrovascular disease. Then there's Lewy body disease. That involves alpha-synuclein deposits and is famously linked to visual hallucinations and Parkinsonian symptoms. Finally, we have frontotemporal NCD. This involves atrophy of the frontal and temporal lobes, and patients often show major personality and behavioral changes way before memory loss ever becomes the primary issue. Moving to Section 4, Delirium versus Dementia. All right, listen up. If you're going to bookmark just one single section of this explainer for your exams and clinical evals, this is it. Let's compare these two head-to-head. Onset, delirium is rapid, dementia is gradual. Course, delirium fluctuates wildly throughout the day, whereas dementia is largely stable through the day. Reversibility, delirium is often completely reversible once you fix that underlying medical trigger, but dementia, it's a progressive, largely irreversible process. And this brilliantly illustrates the core differences exactly the way you'll be tested on them. If you can lock this contrast into your brain, you are going to navigate those clinical assessments with absolute confidence. Before we jump into treatment, I want to throw in a couple of bonus high-yield nuggets straight from our source material. Exam writers love testing the delirium versus dementia contrast, for sure, but they also love throwing in a few other diagnostic criteria to keep you on your toes. So just remember, intellectual disability severity is now defined by adaptive functioning, not just an IQ score. And an autism spectrum disorder diagnosis, that requires two very specific symptom domains. Stick those facts in your back pocket for test day. And finally, Section 5, Management and Treatment Strategies. Spotting the difference is really only half the battle, right? Knowing what to actually do next is how we truly help these folks. Treating delirium means treating a medical emergency. Step 1, play detective. You got to find the underlying cause. Is it a UTI, a new med, withdrawal? Step 2, correct that medical emergency. And step 3 is all about environmental support. You want to reorient the patient by keeping things calm, using consistent staff, and making sure there are visible clocks and calendars in the room. Remember, because delirium stems from a physiological disruption, finding and treating that root cause means the whole condition is usually entirely reversible. Dementia, sadly, doesn't have a cure for its progressive forms just yet, but we definitely aren't powerless. Pharmacologically, cholinesterase inhibitors like donepezil and memantine can modestly slow down the symptoms in Alzheimer's. There are also these newer anti-amyloid monoclonal antibodies targeting early Alzheimer's pathology, though they do come with required monitoring and fairly modest effects. But crucially, it's the non-pharmacological treatments that really lead the charge here. We're talking structured routines, cognitive stimulation, and safety tweaks around the house. We always want to try managing behavioral symptoms like agitation or wandering with environmental strategies before we even think about reaching for the prescription pad. But hey, let's pause for a second, because we really need to highlight the human element here. Caregiver burden is a massive clinical concern all on its own. Managing a progressive cognitive disorder doesn't just happen to the patient, it impacts their entire family. As clinicians, a huge part of what we teach and provide has to be massive education, resources, and emotional support for those caregivers. Because honestly, if the caregiver collapses under all that stress, the patient's entire safety net completely unravels. So, we've covered the rapid-fire emergency of delirium and the steady, gradual progression of dementia, but I want to leave you with a thought as you head back out to the wards and to your studies. As our newer treatments get better at targeting the early pathology of diseases like Alzheimer's, will we one day be able to reverse the gradual decline of dementia just as efficiently as we reverse delirium today? The science is moving incredibly fast, and you, the next generation of focused learners and clinicians, are the ones who are going to find out. Keep learning, keep asking great questions, and I will see you in the next explainer.